Good afternoon, everyone. Welcome back to our anatomy series. Today we continue with the lecture number 4, focusing on the leg, specifically the tibia and fibula, their anatomical relationships and their clinical relevance. We explore the structural features of the leg bones and key landmarks that influence imaging, beam orientation, and therapeutic planning. Understanding lower limb anatomy isn't just about memorizing the bone names. So it's about recognizing how these structures appear in cross-sectional imaging and how they guide clinical decisions in trauma, surgery, and radiotherapy. So let's begin by examining the tibia, its borders, surfaces, and how it interacts with surrounding structures. We'll build from there. We'll build from there toward compartmental anatomy and clinical applications. Okay, let's take a closer look at the tibia, one of the key weight-bearing bones of the lower limb. This slide outlines its anatomical features with emphasis on the shaft and distal articulation points. So now we'll identify the specific features of tibia, one of the main weight-bearing bones in our lower limb. So we'll emphasize on the shaft and distal articulation points. So for radiotherapy students, understanding this landmark is essential for accurate imaging, trauma assessment, and treatment planning. So going to distal end, at the distal end, the tibia and fibula articulate with the bones of the ankle, forming the ankle mortise. So this region is frequently involved in trauma and rotational injuries and it's a common site. It's a common site for injuries. So it's also common for radiological evaluation because of this injury prone nature. So coming to shaft of the tibia, tibial shaft has a very sharp anterior border. So you can see this very sharp, this anterior border. You can see this, it's very sharp anterior border. So this is a palpable border, palpable landmark where it lies just beneath the lies in subcutaneous plane and easily identified in surface centimeter. So this anterior border, sharp anterior border, lies subcutaneous plane. So it's easy to identify. It's a good landmark. So it's critical for incision planning and fracture alignment. So it's very important landmark for incision planning in orthopedic surgery, and also it's guide us to alignments when the fracture alignment when we are doing fracture reduction. So let's go into the lateral side. So laterally it facing the fibula. This is your fibula, so it's facing the fibula. So we can find another sub border in the laterally. This is the border what we call interosseous border. Interosseous border. In this place, interosseous membrane, interosseous membrane, it lies here. So that's why we call this border interosseous border. This membrane divide the compartment into anterior and posterior compartment. So interosseous border attached to this area, this line, we call, so this is interosseous border. So this interosseous membrane separating the anterior and lateral compartments. So anterior and lateral compartments separated by the interosseous membrane, anterior and lateral compartment. So this knowledge help us to understand the compartmental anatomy, specifically when you are doing a physiotherapy in a case of a compartment syndrome. This knowledge is wide. So this is your interosseous membrane, and this is your interosseous border. It separate the anterior compartment from the lateral compartment. So that another important thing is, if you do a transection here, so your transverse section of the tibia, it's a triangular shape. It's an important geometric characteristic, and this helps us in interpreting cross-sectional imaging, and also it's help us to plan our dose distribution around the bony contours. This understanding, because here it's sharp border anteriorly and it's triangular shape bone, so you should plan accordingly. So these anatomical features are not just landmarks. Please remember that they are not just landmarks. They are essential for radiological interpretation and as well as important evaluating trauma scenarios. So we should know these landmarks very well. So now we have come to the end of this slide. So we have discussed the basic features of tibia. So we'll go to the next slide and we'll see a closer look where we can discuss more precisely these anatomical landmarks. Yeah, this slide presents a structural visual breakdown of the tibia and fibula from anterior, posterior, and lateral perspectives. So we'll come to the anterior highlights. Here you can see, as we discussed in the previous slide, anterior border of the tibia. It's a sharp border, and it's it's palpable, and it's a main landmark which is vital for incision planning and fracture alignment. This is we discussed earlier. So here you can see the anterior border. It's very sharp and it's lies subcutaneously. So when you go little bit laterally, you can see the interosseous border which attaches the interosseous membrane, and this lateral border is looking at the your fibula. So fibula, here you should identify the fibula, head and neck. This area is very vital when you are doing surgeries and assessing patients, because your common peritoneal nerve comes and wraps here the fibula neck. So you should know this close relationship when you are planning lateral approaches, and same as when you are assessing the patients with the peroneal nerve injuries, it means foot drop. So this is important landmark area. And when you go downwards, you will see the lateral malleolus. It's a projection of the lateral side. It's a area of interest because it's a very injury. We'll get patients with very frequently with the twisting injuries of the ankle joints, which lateral malleolus fractures or syndesmotic injuries. So this is an area of interest. In here, this projection is the your medial malleolus. So then we'll go into the cross section as we discussed earlier. You can see this is your tibia, this is your anterior side, and this is your posterior side. This is triangular shape in the cross section. So this is your anterior border, which is sharp, and you can identify this lateral surface of the tibia, and this is your medial surface of the tibia, and this is your medial border. So here this is the interosseous membrane which connect the both the bones, fibula and tibia, and it's separate the anterior compartment from the lateral compartment. So this is your cross-sectional view, and here you can identify the posterior border of the fibula, and this is lateral surface of the fibula. So these are the important points to remember from the cross-sectional view. So when you are assessing the CT or MRI cross-sectional images, please keep this picture on your mind. So now let's move on to the posterior side. In the posterior side, main landmark is the soleal line. So soleal line is the main landmark in the posterior side. Here you can see this overlapping of the tibia and fibula at the distal end. And here specifically you can see special grooves. There are for two prominent grooves you can identify in the distal end from the posterior side of the ankle joint. So here you can see from the medial side, this groove is for the tendon of tibialis posterior muscles. It runs here just posteriorly in the medial malleolus. So this tendon, posterior tibialis tendon, lies very close to the deltoid ligament, which is here. So when you go to the laterally, there's another groove. This groove provide the area to travel. This in this groove, fibularis longus and brevis muscles will travel in this lateral groove. So these are the important landmark of the distal tibia in the posterior side. So then here is another, this picture you can see, it's a closer view. So here you can appreciate, you can identify that this is your articular surface. This articular surface articulates with the talar bone, talus, and you can see this area, rough area. This is called fibular groove of the tibia. It's a roughened area, and triangular. This shape is a triangular shape and fits into the fibular groove of the tibia. So now you can identify this. Now this is a closer view, this triangular shape, sharp anterior border of the tibia, and introduce this membrane and introduce a border, and in fibula head and neck. It's important in assessing a foot drop scenarios like foot loop. You can remember we discussed in the femur linea aspera. Here likewise it's an important line is soleal line. Okay, now we focus on the fibula, the slender lateral bone of the leg. Though it's not weight bearing, its anatomical relationships are vital for stability, muscle attachments, and for our surgical planning, because it's important for surgical access. So head at proximal end, the fibula head articulate with the lateral condyle of tibia at proximal tibio-fibular joint. So in the proximal tibio-fibular joint, head of fibula articulates with the lateral plateau, lateral condyle of the tibia. So it's articulates the lateral condyle of the tibia from the lateral side. This joint, this joint calls proximal tibia-fibular joint. This joint allows slight movement. So it has a slight movement with accommodating ankle motion and load transmission. So proximal tibia-fibulum joint has a minimum movement, and it's accommodating little bit of motion of ankle and load. So neck of fibula, it's just below the head. So it's very important. You can see the narrowing of the bone there. So clinically it's important, as I mentioned earlier also, as the common peroneal nerve winds around it. So this is very important in assessing trauma or surgical planning, because damage to common peroneal nerve in this area will result in foot drop. So you should, when you are operating in this area, you have to do careful dissection to avoid nerve injury. So the feature of this shaft is very thin shaft. The shaft is long and slender. So it's providing attachment for muscles like fibularis longus and brevis. So it provides attaching site for muscles like fibularis longus and brevis. It's often harvested. Yeah, it's often harvested for bone grafting due to its expandable nature. Yeah, in plastic surgery practices especially, they take fibula grafts. So it's a important bone for grafting. So it has a border called interosseous border from the medial side of the bone. It faces the tibia and anchors the interosseous membrane. This structure separates the anterior and posterior compartment. So understanding this border helps in compartment. It's a This understanding helps to identify the proper compartment in cases like compartment syndrome. If you are doing physiotherapy, so you should know these landmarks, and this also you should know. This will help you to plan your radiotherapy field planning also. And other thing is, sometimes with ankle injuries, distal ankle injuries, you may get proximal fibula fractures also. What we call this myocene fracture. So always you should assess the syndesmosis, and you should see the X-ray for the widening of clear space, medial clear space. You always in the X-ray. So these are very important role assessing the trauma scenarios with the twisting injuries. So the fibula's role in lateral stability and its proximity to neurovascular structures make it a key landmark in both trauma and radiotherapy methods. So it is very, though often overshadowed by the tibia. Yeah, so most of the time this bone is overshadowed by the tibia. The fibula plays a crucial role in leg anatomy, surgical planning, and radiotherapy contouring. Let's keep its landmark in mind as we move towards the ankle and foot anatomy. Yes, coming to interosseous membrane, this slide illustrates the interosseous membrane. This is a fibrous membrane. This is a fibrous sheet connecting the tibia and fibula, much like its counterpart in forearm. So, same as its counterpart in forearm, it connects tibia into fibula. This make the connection. So it plays a vital role in compartmental integrity, muscle attachment, and vascular transmission. So it's an important structure as it's helped the vascular transmission, and as in the forearm here also there are some muscle attachments. So these two interosseous borders connect the tibia and fibula. So these are the interosseous border of this is the fibula, and this is the interosseous border of the tibia. So this connection, so this interosseous membrane connect the tibia with the fibula. So this connection stabilizing the bones and maintain leg architecture. So this connection helps to maintain the leg architecture. So actually this is not a true joint, it's considered as a syndesmosis. So it's not a true joint, but it's crucial for load distribution and muscle coordination. So as I mentioned earlier, it has attachment site for leg muscles, especially those involved in dorsiflexion and toe extension. So you see this have a note on this fiber orientation. These fibers slope obliquely downward. Okay, these fibers goes obliquely downwards from tibia to fibula. Okay, this orientation support mechanical stress transfer and guide muscles force. So it's actually it's helpful to transfer the force. It's this orientation is from tibia to fibula obliquely downwards. It's a subtle but important anatomical detail. Okay, even subtle, it's an important detail. This muscle orientation, this fiber orientation, because it's plays a vital role in functional biomechanics. So you see this opening, yeah, here there's a opening. So this opening in the membrane that allows the anterior tibial artery to cross from the popliteal fossa to the anterior compartment. So this is important uh, point we should make note this. It's in the superior portion of the interosseous membrane, there's an aperture for anterior tibial vessels. So this is a key vascular landmark. So especially when you are assessing trauma patient with compartment syndrome, also it's important when you are doing your radiological mapping also. So this is a very important point to remember. This is the aperture for anterior tibial vessels. So what's the clinical relevance in this membrane? In compartment syndrome, the interosseous membrane acts as a barrier, limiting pressure dissipation between anterior and posterior compartments. So this acts as a barrier. Okay. Uh, in radiotherapy, accurate mapping of this membrane. So if you do the accurate mapping of this membrane, it helps to avoid unnecessary exposure to vascular and muscular structures. So if you can map this thing properly, so you can avoid unnecessary exposure to other structures. So this is the interosseous membrane which connects the tibia and fibula. So it has attaching by the interosseous borders of the tibia and fibula. Its fibers runs obliquely downwards, and it's not a true joint, it's a syndesmosis as we all know. And there's a picture for the anterior tibial vessels which are coming from the popliteal fossa and crossing this membrane, it's enter the anterior compartment. Let's move on to the distal end of the tibia fibula. This distal tibia fibula joint is a very important joint. It's not actually a synovial joint, it's a fibrous joint made out of strong ligaments. So you can see here, this is our distal tibia fibula ligament. So there are two main ligaments which are supporting the distal ankle joint. First one is anterior tibia fibula ligaments from the front. It stabilizes the ankle joint with during the dorsiflexion, and this posterior tibiofibular ligament, it's prevent the posterior translation of the translation of the fibula. So these are the two main ligaments supporting the distal tibiofibular ligament. Other than that, interosseous membrane also help for the stability of this distal joint. So as I mentioned earlier, though it's not a synovial joint, its integrity is essential for ankle stability and load transmission. So this is the important points what we need to notice is this joint unites the distal end of tibia and fibula. So, and this syndesmosis is a fibrous strong joint. Its stability is very important for the ankle stability. Whenever you are assessing a patient with ankle trauma, you should assess the stability of syndesmosis also. So not only the bone, other ligaments, syndesmosis stability also you have to assess, because it's crucial for maintaining the ankle motility. So when we go further, we know that interosseous membrane support the continuity, and also these interosseous membrane contributing to joint stability and compartmental separation. So especially in high ankle sprains, you should think about syndesmotic injury also. So it's very important. So disturbance or disruption of the distal tibiofibular joint can compromise ankle mechanics. So it's very important joint. So even it's important during radiotherapy contouring to avoid unnecessary exposure to prevent these functions. So in summary, distal tibiofibular joint, it's not a synovial joint, it's fibrous joint, and it supports the motility of ankle. And there are two main ligaments. One is posterior tibiofibular ligament, and one is anterior tibiofibular ligament. Another structure is the interosseous membrane. So this is the important point of the distal end of tibia and fibula. So in the anterior tibiofibular ligament support during dorsiflexion, and posterior tibiofibular ligament prevent the posterior movement of the fibula. As we conclude our exploration of the leg, now we arrive at the ankle motility, a structural masterpiece that integrates the tibia, fibula, and talus into a stable weight-bearing joint. So this is a very important structure, motility, made out of distal tibia, fibula, and talus. So components of motility are the main. There are three main components. So they are lateral malleolus. You can see this is your lateral malleolus of the fibula. Then medial malleolus of the tibia, and the inferior articular surface of the tibia. So inferior articular surface of the tibia, you can see this is inferior articular surface of tibia, which is going to articulate with the talus. So medial malleolus, lateral malleolus, inferior articular surface of the tibia. These structures, so these structures straddles the talus, forming the ankle joint. So this talus smoothly moving the in between these structures. So this is what we call ankle mortise. So, the posterior tibia fibula ligament completes this structure, because it should be this posterior tibia fibula ligament should be very strong to hold the integrity of mortise. So it's we saw in the previous slide that how posterior tibia fibula ligaments located. So it is a very strong ligament. So it's support for the stability of the ankle mortise. So this joint must be exceptionally strong. Okay, this joint should be very strong. Otherwise, any laxity allows the talus to ride upward during activities such as running. So it is very important, especially because all the body weight translated through this joint, especially high impact activities such as running, walking. Right here, you can see this transverse card. You can see how it's look like this is the look of the talus. Okay, so you can see this peculiar arrangement. This articular surface is narrow in the posterior and it's wider in the anterior. So this arrangement help preventing the dislocation during dorsiflexion, because this broader part can't go more inside during the movement, so it's prevent dislocation. It's peculiar. So you see this, the posterior articular surface is smaller, narrower than the anterior articular surface of talus. So this is the peculiar arrangement to prevent or overriding up of the this talus between tibia and fibula. So high ankle sprains involve disruption of the distal tibia-fibular syndesmosis. So this may compromise the mortise. So whenever high ankle sprain, high ankle injuries, you should keep this in your mind. So in radiotherapy, planning precise mapping of the mortise is essential to avoid collateral damage to the joint. So especially when you are doing the mapping, you should keep idea about this mortise, because any damage to the mortise may have long-term consequences. So as clinicians and educators, understanding this structure help us diagnose, treat and teach with clarity and confidence.